So another part of managing alcohol use disorder is when an individual presents with acute alcohol intoxication. Now, people can present intoxicated on alcohol without having alcohol use disorder, but certainly they can absolutely go hand in hand. If it is an acute heavy ingestion of alcohol, supportive care is going to be one of our primary interventions that we will provide. Things like hydration, most of the time, because alcohol is fairly rapidly absorbed into the system, things like gastric lavage, so pumping the stomach, or charcoal are not often used. And of course, things like education. Some people just have an interesting evening and require a little bit of education on safe alcohol use. If someone is known or suspected, or we don't know, to have chronic alcohol ingestion, then there are some nutritional deficiencies to take into consideration that can have some pretty significant consequences if not addressed. So we have what's often referred to as our banana bag, largely because it's got a lot of nutrients and it's yellow most of the time. Includes things like thiamine, folic acid, magnesium, and multivitamin. So that is something that's often administered in the acute setting. If someone's in the ER, for example, they'll get an infusion called a banana bag. When it comes to thiamine and folic acid doses, there are some variances in what is recommended. My suggestion is, anywhere from 100 milligrams daily to 500 milligrams intravenous 3 times a day can be recommended. You'll see some places that suggest it, but understanding that a consistent dosing of thiamine and folic acid is important to help prevent some of the fairly potentially significant neurological toxicities from basically kind of like a refeeding, et cetera, from alcohol use. So what is that? Briefly, so our students have seen this before. So just very briefly, there's risk of what we call Wernicke-Korsakoff, sometimes referred to as like a wet brain, if you will. And it can be prevented with, addressing a thiamine deficiency. And thiamine is fairly safe to give even if someone may not have thiamine deficiency. So the risk is pretty low of giving thiamine. And basically, Wernicke-Korsakoff is 2 pieces. There's Wernicke's encephalopathy and then Korsakoff syndrome. So Wernicke's encephalopathy is characterized by ataxia, so movement issues, confusion, disorientation, some ocular motor dysfunction, and can be quite dangerous. It can also lead to Korsakoff, which is characterized by chronic amnesia. People will confabulate, lots of memory and like organization of thoughts challenges from Korsakoff. They tend to have a hard time being insightful. They can be apathetic. So we want to really try to prevent these because sometimes these can be permanent or very difficult to treat. Now, in addition to that, there are people who might be at risk of experiencing acute alcohol withdrawal. And that risk varies from person to person, depends on how much they've been consuming, how long, other risk factors. But they can follow a pretty well-known timeline of events, okay? So early onset symptomatology of alcohol withdrawal tends to be things like tremor, headache. We can see high heart rates. We can see fluctuations in blood pressure. Some people will feel mild symptoms like this, even just as part of their, what we refer to sometimes as a hangover. Usually about 12 hours in, especially if someone has extremely high alcohol intake and has extremely reduced or stopped altogether, we can start to see some pretty significant psychiatric manifestations, which can be vivid hallucinations. They can be auditory, they can be visual. We see tactile hallucinations as well, like bugs crawling on their skin, and significant feelings of anxiety, as well as continuation of those other physical symptoms like tremors and blood pressure changes. And then the concerning part is what we call the alcohol withdrawal syndrome, historically referred to as delirium tremens, and this is potentially quite dangerous. So we see significant autonomic dysregulation. People's even body temperature maintenance can get kind of dysregulated. They become delirious, so this lack of orientation to what's going on and can cause things like agitation. And we can also see things like seizures with the acute alcohol withdrawal syndrome, which can be quite dangerous. So we want to make sure that people are being monitored and treated appropriately. So visual aid timeline, right? So anxiety, so the milder symptoms can happen fairly quickly. We can see seizures even earlier depending on individual factors, but the delirium tremens or the alcohol withdrawal syndrome can start usually about 48 hours in and can be quite protracted. They can last a long time. Now, what increases someone's risk of having these severe or complicated alcohol withdrawals? If they've had it before, if they've withdrawn from alcohol multiple times, if they have other comorbidities that can increase the risk of some of those symptoms, so things like a history of a traumatic brain injury. Older individuals, if they have used for a really long time with heavy use, if they have what we call autonomic hyperactivity when they come in, and if they have kind of codependence on other types of CNS depressants, typically benzodiazepines or barbiturates. Now, how do we assess it? The most common scale that's going to be used to assess alcohol withdrawal is called the CIWA, or the Clinical Institute Withdrawal Assessment for Alcohol Scale Revised. And this can be categorized into mild, moderate, severe, and complicated with a variety of symptoms associated with those. So you can kind of see that here, right? So anxiety, sweating, insomnia. They look at tremor. They look at confusion, hallucinations, delirium, etc. So this is often what's ordered when someone comes in and there's a concern for potential for alcohol withdrawal. They'll get their thiamine and folic acid order. They'll get their CIWA order for usually every 1 to 4 hours, and associated orders for things like medications. So on the inpatient side, as I mentioned, every 1 hour to 4 hours for at least a day, and they're checking really to kind of make sure that the CIWA doesn't start trending up or start spiking. If their CIWA stays fairly low, that mild to moderate for a full day, then you can back off on the frequency. Usually we will monitor for at least a few days to ensure that the individual isn't going to fit into that 48-hour things get bad kind of situation. So we do monitor for a good period of time. If they have milder withdrawal, if they are lower risk, you can just do it every 4 hours just to be careful for up to about a day and a half to 2 days. Just kind of depends on the situation. And of course, with alcohol withdrawal, there are different levels of care that can be appropriate for that individual. So our level 1 that has a milder case, there's no other reason that they might be admitted for management. They can do it on the outpatient side, right? If they're going through an alcohol withdrawal, and that usually just includes daily monitoring for several days, usually up to about 5 to 7 days. Second level is people who might have more agitation or symptoms, then they may need to bump up into more of an inpatient type of scenario. And absolutely, if their CIWA is in that higher risk space, so 19 or above, or if they have other significant concerns like other conditions, if there is a risk of harm, if they are not going to be able to engage in appropriate monitoring and follow-up, then they can go on the inpatient side. So when we actually treat with medications, the treatment of choice is by and large benzodiazepines. There are some caveats there. We have things like certain barbiturate that can be used, but by and large with the guidelines and recommendations, benzodiazepines tends to still be the gold standard in a lot of cases. Using benzodiazepines can help reduce complications. It's considered safe and effective to utilize benzodiazepines for management of acute alcohol withdrawal. Most commonly, you're going to use symptom-triggered treatment. So based on their CIWA score, they will receive an associated medication dose. Okay. Sometimes, though, we will do a scheduled kind of taper or a scheduled front load where they're getting the medicine and then we come off the medicine, but the medicine's being provided at specific time intervals, regardless of their CWAS score. But the most common one you'll run into in clinical practice is going to be the symptom-triggered benzodiazepine administration. Now, theoretically, all benzodiazepines are created equal. We tend to like to use ones that have no significant active metabolites, especially if someone's older, if they have liver disease, so things like lorazepam and oxazepam. For some people, if they find that they have significant rebound symptoms when the benzodiazepine starts to wear off, we can use some of our longer-acting products like chlordiazepoxide or diazepam. But truly, the most common one that you're going to see in clinical practice is going to be lorazepam. It's just one of our most common benzodiazepines that we use. People are really comfortable using it. A lot of the CWA order sets that you'll run into will be lorazepam focused. Other options. I did mention before that phenobarbital can be an appropriate option. There's weight-based and standard dosing available. That's been discussed previously, usually reserved for people who have high risk of severe withdrawal, but you can load people pretty significantly with phenobarbital, and it's pretty safe to do, which is awesome. You can also use gabapentin in divided doses, carbamazepine, although this isn't very frequently used, with a kind of scheduled dose and a taper from there. And then, of course, if someone has really significant alcohol withdrawal, one of the challenges, they may require really high doses of CNS depressants, high doses of benzodiazepines, and they may require ICU level of care. In those cases, other agents such as dexmedetomidine or Precedex and even propofol may be part of their treatment to help really kind of help them get through withdrawal. Dexmedetomidine is nice because it doesn't have as much of like a significant effect on someone's ability to protect their airway as CNS depressants like benzodiazepines do. So there are some other options there as well. I just quickly wanted to spend a few moments talking about some of the comparisons between alcohol and benzodiazepines. So they do have some similarities in terms of their effects in the CNS, and people can have dependence upon benzodiazepines as well. So some differences, things like management of overdose. So we may have a better support for using things like gastric lavage in overdose of benzodiazepines, but we're still doing things like supportive care and respiratory support. So remember, CNS depressants sometimes make your brain forget how to breathe, right? So we have to be really careful and make sure someone's getting oxygen right into their system. There is a reversal agent for benzodiazepines, fairly uncommon to use because the risk of precipitated withdrawal with benzodiazepines can be pretty concerning, can precipitate things like seizures. So not often used, but we do have flumazenil that can reverse the effects of benzodiazepines, similar to naloxone reversing the effects of opioids. Withdrawal, similar, right? We have supportive care, benzodiazepines. Benzodiazepines should be tapered in really both cases, but we're more likely to do a scheduled taper with a benzodiazepine use disorder presentation versus alcohol use disorder presentation. And then there are more things when it comes to options for deterrence and medication treatments that are FDA approved for alcohol use disorder versus benzodiazepine. There's not really FDA approved products that are recommended or used for benzodiazepine use disorder. A lot of times it is that psychosocial aspect that they focus on. But when we are tapering benzodiazepines, it is really important to do it in a safe way. And that depends on a ton of different factors. It depends on the individual's dose, how long they've been taking it for, sometimes what they're taking it for, what our ultimate goal is, etc. And it's important to realize that individuals can have what's called a protracted withdrawal of benzodiazepines, that they have persistent effects from that withdrawal for weeks to sometimes months. And this is true with alcohol as well. But things like difficulty sleeping, irritability, anxiety, absolutely can happen. Sometimes even with benzodiazepine withdrawal, we can see a precipitation of catatonia. So we have to be a little bit cautious about how and when to taper benzodiazepines and how to do it responsibly and with appropriate monitoring. So really, anytime you're using a benzodiazepine regularly for, frankly, 6 to 8 weeks or more, it should be considered to be tapered. And if someone has been on, say, benzodiazepines for years and years and years, this might be a 6+ month endeavor where we're reducing by 10% of their total daily dose for a month or two, and then 10 more percent. It really depends on the individual. If things like anxiety come up, or if they have difficulty sleeping, if they have, residual symptoms, psychotherapy can be really beneficial. Other non-benzodiazepine interventions can be considered as well. Then, of course, we want to think about other complications. So if someone experiences withdrawal seizures, then we got to increase that level of care if they are not in ICU care yet. And a lot of times we'll use intravenous benzodiazepines to suppress the seizures and prevent seizures to happen again. And if they experience that delirium, same thing. Typically ICU, often they'll need one-to-one care and IV benzodiazepines. As I mentioned before, with benzodiazepine overdose, we can reverse it, but it's not frequently done. What does a benzodiazepine overdose look like? All this kind of stuff here, right? So its biggest characteristic is it's a CNS depressant. So we will see breathing reduction, right? We'll see blood pressure start to decrease. We can sometimes see heart rate decrease. The pupils can become large, which is different than opioids. People can fall into a coma. These products are used in anesthesia at those high doses. We can absolutely, induce anesthesia and make people really, really sleepy with benzodiazepines. Pulse can become much less noticeable, and if that blood pressure gets really low, then sometimes instead of like a slowing down or calming of the heart rate will try to increase to sort of restore some of that circulation. So we can see the pulse actually kind of spike up in those situations as well. And of course, there is a risk of dying from a benzodiazepine overdose. It's not super common in cases where people unfortunately pass away from medication or illicit substance overdose. If benzodiazepines are involved, they're often involved with other substances as well. Okay. All right. So the next section is going to be more of the maintenance treatment of the alcohol use. So we're going to stop here and pick up on the next section.